Thank you very much, and thanks to the organizers again for the opportunity to speak today. Excellent. So, as was just mentioned, I am an infectious disease doctor, and for those of you who know infectious disease doctors, you'll probably know that we're not so good at answering questions, but we very much like to ask questions. So I'm going to respond to the question that was asked to me today with many questions for all of you that maybe we can answer together. The question that was asked to me was, how should we integrate cardiovascular disease prevention into the care of people with HIV in low and middle income countries? And as Dr. Bhattacharya and others have mentioned already today, that question for high-income countries, I think, has been answered pretty well with what we call in the United States a slam dunk. That's a basketball metaphor for those who aren't sure. And of course, the REPRIEVE study showed very clearly that in people with HIV at low to moderate risk of cardiovascular events, you can reduce those events by about a third, 36%, for people who take pitavastatin or statin versus placebo. And very soon after the study was published, the United States, the United Kingdom, and other parts of the world that I think were very highly represented by the study immediately and appropriately came out with guideline changes to reflect that recommendation. But what do we know about low and middle income countries? What does the evidence tell us there? And Dr. Bhattacharya actually mentioned this, and this is a modeling study, which I think is very important. If you look at modeling studies and you take the risk that we're now are very aware of in high income countries, which is about a doubling of the risk of these cardiovascular events, and you combine that with areas of the world like parts of sub-Saharan Africa that have very high prevalence of HIV, what you'll find is an incredibly high modeled burden of cardiovascular events, an incredibly high burden to humans, to health systems that needs to be responded to. But what happens when you look at data directly from low and middle income countries about HIV and cardiovascular events? Well, I think these data are just starting to emerge. This is preliminary data, not published. It's actually currently under review, where people with HIV who are at clinics and virologically suppressed in Uganda, in rural Uganda, and then HIV uninfected comparators, people without HIV, who are otherwise similar in terms of age and sex, all underwent CT imaging, just like the kind Dr. Bhattacharya just mentioned, with contrast-enhanced scans of the coronary arteries. What was found in Uganda was no difference in the prevalence of coronary artery disease, the type of coronary artery disease, the severity of coronary artery disease between people living with HIV and people without HIV in the same communities. But perhaps even more importantly, in that study, when you compare the prevalence of coronary artery disease in Uganda from other population studies that are otherwise similar in terms of age and sex, you find a fraction of the prevalence of coronary artery disease in Uganda that you do in South Korea or Sweden or the United States. But this is prevalence of disease. This is kind of like step 3 in that paradigm that Dr. Bhattacharya just showed. What about step 4, which is events, which is what we're most interested in? So one of the best things, and there are many great things about the REPRIEVE study, was that it was a global study. We can learn a lot from this study, regionally. And of course, there were over 4,000 people from high-income countries, but there were over 1,000 people in the sub-Saharan African region who were enrolled in REPRIEVE and followed longitudinally to detect events, cardiovascular events. What was found in that region? Well, if you take a step back and you look at the entire study, this is the incidence of major cardiovascular events in the entire study, as been mentioned multiple times. In the placebo group, the dark bar here, there's about 8 events per 1,000 person years. That was reduced to 5 per 1,000 person years in the pitavastatin group. The rates were higher in high-income countries, 11 in the placebo group and only 7 in the statin group. So extremely common and a strong reduction in events. What if you look at other regions? Now, this study, of course, wasn't powered to show other regions, but there are patterns here that are important. The first pattern is that rates are much lower in Southeast Asia, in East Asia. In sub-Saharan Africa, there were only 3 events per 1,000 person years in the placebo group. So as an epidemiologist, even though the reduction existed, we like to convert those kinds of findings to what's called a number needed to treat. How many people do I need to give pitavastatin to prevent one cardiovascular event? Well, in the total study, it was 73, which is a pretty decent number. It's better than aspirin and some other preventative interventions. In high-income countries, you only need to give 55 people a statin to prevent a cardiovascular event. That's good money. That's good value there. In sub-Saharan Africa, that number was 144, and that's because the event rate is so low. So let's put that into context. Statins cause diabetes. This is known. In the REPRIEVE study, for every 78 people you gave a statin, 1 case of diabetes was caused. So you're going to have twice as many cases of diabetes for each cardiovascular event you prevent in sub-Saharan Africa if these numbers can be extrapolated to the population. The number needed to harm for one case of myositis or weakness, grade 3, which is another side effect of myositis, was also less than the number needed to treat for a cardiovascular event in sub-Saharan Africa. So clearly, you want to prevent cardiovascular events, and that's probably more important than causing a few cases of myositis. But it's important to note that the calculus is different here. It's different than it is in high-income countries, and we need to be focused on the interventions we do in low-income countries before we roll them out. And so, in my mind, Reprieve answered some questions very clearly in high-income countries. But in low and middle-income countries, it may have asked more questions than it answered. So, for example, how hard will it be to roll out something as simple as statins in low and middle-income countries? This is data from the HPAC study, which is a beautiful global cohort, which takes data from around the world and estimates rates of cardiovascular morbidity and health system strength. And if you focus your eyes here on the Africa region here, this is the proportion of people using statins in Africa. For primary prevention, from those who are eligible, less than 10%. For secondary prevention, people who've already had an event, only 15% in sub-Saharan Africa who qualify for statin use are on statins. So we can't snap our fingers and say statins are going to go in use. There's a lot of work to be done to figure out how to roll out these medicines or other preventative interventions in this part of the world. What do we know about integration of HIV and NCD services? Of course, a landmark study, which I'm sure many of you know about, published in the Lancet last year, tried to ask this question in East Africa. They took 32 clinics and they randomized these clinics in a cluster randomized fashion to standard of care, which is separated HIV and NCD care, or integration of care. And the good news from the study was that integrating care did not affect virologic control. People living with HIV were just as likely to be suppressed if they were integrated care versus standard of care. What about NCD control? Well, I would say there was a modest, if not minimal, effect of integrating care on blood pressure control, about a 10% increase in the prevalence of blood pressure control. But there was no difference in diabetes control. So again, it's not just, are we going to integrate NCD services or preventative services? The question is, how do we do that? Have we learned the lessons about the best way of doing this? There's multiple models of integrative care. We can just take HIV clinics and integrate NCD care into them. We could also take chronic disease clinics and have people with HIV and people with chronic diseases go there together. There are pros and cons to both these models. We're happy to talk about this during the Q&A session, but I think these are really difficult questions that we have yet to answer. We can't just say we're going to start doing preventative care. We need to think about the model and, of course, how complex it is. This was one study from Uganda that tried to integrate care services from an HIV clinic and an outpatient chronic disease clinic into one clinic, and they found a 40% increase in waiting time. This is just one example. There are many different studies like this that have shown the complexity of care when you integrate services. How much will it cost? This is a study from Sten Vermeulen and colleagues looking to see how much would it cost to integrate NCD care into HIV care in South Africa. These are billions of rand. Long story short, they estimate that between twice and 3 times the national South Africa budget for primary care services will be required to integrate these two services together. Dr. Bhattacharya already mentioned this. I won't delve into this. If we talk about where this money is going to come from, historically speaking, donor funds from high-income countries to low and middle-income countries for healthcare services have been focused on HIV, TB, malaria, maternal and child health, the health priorities for the last 3 decades. But if this paradigm is going to change, this piece of the pie is going to have to increase. Right now, we don't have the funds to afford this type of integrative care services. And then I think perhaps most importantly, and something for us to discuss, is what should we prioritize? This is a study just recently published in the Journal of the International AIDS Society by Krishna Reddy and colleagues that took a population of people living with HIV in South Africa and found that amongst people suppressed, tobacco smoking decreases life expectancy more than HIV. So is it statins that should be integrated into care, or is it tobacco cessation? The Global Fund last year, as I'm sure you all know, put up this guidance note that says when we start to integrate services, when we think about this framework for supporting health for people living with HIV, we have to be doing it globally speaking, not just in terms of regional, but in terms of humans and their needs. These strategies need to be supported by strong data-driven investment cases. They need to reflect patient-centered care, people-centered care, and to prioritize integration of care services. Unfortunately, or maybe fortunately, they also showed there's a tremendous need. Childcare, maternal care, prison health services, school health services. These are decisions that ministries of health and ministries of finance need to make, and it can't be everything. We need to be focusing our efforts with the highest bang for the buck and the best outcomes for the people living with HIV worldwide. So instead of answering this question, how should we integrate cardiovascular prevention into the care of people with HIV? Should Reprieve say that statins should be the next thing we do? I think the question really should be, which prevention services should we be integrating into care? What services? What are the best ways of integrating that care? And what data do we need to really help guide the decision makers and the policymakers to answer these two questions? Thank you for your time and attention. I look forward to the discussion.